you.
So Dr. Dickie is a surgeon at Boston Children's. So we weren't getting answers. We had a GI doctor in Connecticut, but he wasn't really I don't want to say you were more aggressive, but like with the surgery part, like she sort of pushed us in that general direction. He was a little bit more laid back, and we were just sort of trying medicines after medicines after medicines, and like we just got to a point where we were like, we need another opinion, and we just sort of went with it. And we're, like I said, we're in a much better place. So she's at the Boston Children's, and she's co-director of the Colorectal Center and Pelvic Malformation Center. Got her medical degree at the University of Toronto, in Ontario, Canada, and completed her general surgery residency and PhD at the University of Alberta. She continued her education by completing a fellowship in advanced minimally invasive surgery at the University of Alberta. Upon relocating to the U.S., she continued her training in pediatric colorectal surgery at Cincinnati Children's and Vascular Malformations at the University of Florida. Her focus includes pediatric colorectal surgery in anorectal malformations and reconstructive surgery, Hirschsprung's disease, inflammatory bowel disease, and motility disorders. She's one of the leaders in using minimally invasive surgery and robotics. She's participated in surgeries and taught courses around the world on advanced reconstructive colorectal and pelvic surgery. Her second focus is on vascular anomalies and the genetics of these disorders. And she has 2 sons, and that's what she does on the side. Everything else is poop.
Here. Thank you for that introduction. I was here, Katie and I were just chatting. I was at the Mowat Wilson conference in 2017 in DC, and it was very eye-opening for me to see the spectrum. And I'll go through a little bit how I got involved in this, but you know, we have to keep this a little bit lighthearted. It's a small group. If you have questions, please interrupt and ask. I don't know where you all are from. I'm happy we can do introductions and stuff, but you probably know each other, and we'll sort of get started. But like I said, just interrupt. This is going to be really sort of general because it's hard to, in these settings, to sort of give specifics. But if you have questions afterwards, I'm more than happy to answer. So, I mean, I think the biggest thing to realize is the pooping part is sometimes the most stressful part, right? No one wants to talk about it. No one wants to talk about my kid can't poop. I'm having troubles because it's supposed to be normal. And so as a surgeon, you know, we get into it sometimes on the later end because you're seeing your pediatrician, you're seeing your gastroenterologist. But our group and a lot of the colorectal centers around the US and Canada and the world actually are more into sort of the bowel management with, as Katie says, not aggressive, but we're probably a little bit more aggressive in both medical treatment and then offering what we can do. Because some kids do need surgery, some kids don't, you know, just need a higher sort of dosage, need a higher sort of routine to help things empty. Because really, you know, everyone's been constipated in their life probably at one point in time. If you can't poop, you don't feel good. And if you don't feel good, then it affects everything. And so that's sort of where we come in. So I work at Boston Children's Hospital. I've been there for now almost 7 years. And we have a whole center dedicated to kids with pooping issues, whether congenital, whether acquired, and as Katie said, motility disorders. We follow quite a few Mowat Wilson kids. And so we sort of have a feel for how to that. I have a big team of gastroenterologists. We work with nurses, nurse practitioners who are your like lifeline. They're my lifeline, but they're also your lifeline. Because we do a lot via virtual emails, phone calls, and appointments online. We try and tout ourselves as a multidisciplinary center in the sense that we try and bring in all aspects of care that your kids and your families may need. Because pooping is not just pooping, it's everything else involved in it. I got introduced to Mowat Wilson when I was in Cincinnati, and there was, I think, 2 families within like a very short time that came in who couldn't poop. One of them had Hirschsprung's, one of them didn't have Hirschsprung's, and it was sort of this was a whole different realm of not being able to poop. And so I think that's when I first met Deb, and we were able to help in that realm, and there was a couple other kids who we were able to help. And it's a lot of an awareness thing, right? So I now, when somebody comes in with certain diagnoses as a baby and we're working them up, it's like, did anyone think about Mowat-Wilson? Maybe we should get genetics on. Maybe we should do a rectal biopsy. So I think the more that we spread the word about it, and from my side as a surgeon, I can do it because we see kids who can't poop when they're born. We see kids who have malrotation, and we see kids need feeding tubes because of the absent the brain issues. And so being able to understand this helps us help you guys in the end. And so for us, we really want to work as a team with you. What we want to do is help you get to where you want to go with your families. Today, I'm going to go just a little bit and talk about, it doesn't bother me if it doesn't bother anyone else in the room, seriously.
He's fine.
Yeah, he's fine. No. I can even talk louder, but I'm just, okay. No, it doesn't bother me, honestly. Yeah. So.
I have a question already.
Yeah.
Do you know of other centers like yours that are in other states?
Oh yeah, so there's a lot of colorectal centers around the world and around the states. I don't necessarily know how many know about Mowat-Wilson. I was lucky. I mean, I met kids early on in my career that had this, and you just start putting pieces and patterns together. But I think from my point of view, like our fellows, like the people I train, know that if you see these things, maybe you should think about that, right? And so.
I know in 2017 I talked to you in Washington, and you directed us to Dr. Garrison and Dr. Krischer at Cincinnati Children's. They're amazing also.
Yeah. So I have a list at the end of the talk. Yeah, I have a list at the end. Yeah. I mean, that's where I train. That's where I used to work, and so they have a great group there. I mean, there's almost somebody everywhere in the region, in the country now, who does do colorectal. It's sort of, I don't want to say it's a spreading field in the sense that it is, we know what it's important for families, not just for Mowat-Wilson, but a lot of other sort of diagnoses and issues, that it's helpful. And so there are places across the country. And like I said, I have a list at the end. I was going to go through a little bit about Hirschsprung's disease because it is very particular, and then just what we do for constipation and how we do manage it. I mean, we know that more than half of the kids with Mowat-Wilson potentially have Hirschsprung's. That being said, probably all of them have issues with pooping. So even if you don't have Hirschsprung's, you have issues with stooling. And so it truly is sort of a spectrum. Hirschsprung's in itself is a spectrum of disease. Like there's kids who we do something and they're fine. There's kids that need surgery. There's kids that need more surgery. There's kids that can't poop even if we do surgery. So there's all these different things. And then, you know, my perspective, and I think what the society or the family group has suggested, and the medical advisory board, is all kids should be screened if they have a diagnosis of Mowat-Wilson for Hirschsprung's. It's a when you're small, when you're a baby, it's probably a pretty easy test to do. As you get older, it gets a little bit more complicated because it's a rectal biopsy. And so it's
we went in, they just did like the
the contrast study.
Do you think that's enough? I mean, we tested for Hirschsprung's multiple times.
Yeah.
In 2014, when we were in Kansas City, one of the big takeaways we took was, I think it was Dr. Wilson, one of them. Dr. Mowat or Dr. Wilson at the time thought it was 100% correlation between Hirschsprung. So we walked out of there going, wow, like he thinks every single kid has it in 2014. So we went and got her tested multiple times, multiple ways, because it kept coming up negative.
Yeah.
And so he was so adamant about it that we kept testing her. Like, we just must make it.
Well, the problem is both Hirschsprung's and probably the presentation of stooling in Mowat-Wilson is so variable, right? And so the definitive test for Hirschsprung's is actually getting tissue and looking at it in a biopsy. But that being said, The biopsy tells us if there's those nerve cells or not. If they are there, we don't know if they function normally, right? So that's where the whole constipation, motility workup, and all that sort of stuff comes into play as well. Because the kids may have the cells, but it still doesn't work well. And so, but the definitive test for Hirschsprung's is getting a rectal biopsy, because there's actually a surgery we can do to help that. Doesn't always solve things 100%, but it might help. All right.
Is that a separate test, excuse me, for motility?
There's different tests for motility. Yep. Well, I can go through some of those with you guys. Okay.
We also did a Botox in the rectum. Yep.
You can put Botox anywhere now.
And my son does have ganglion cells, but he's never stooled on his own, so they don't function, even though he
Yeah.
has them through his entire
Yeah.
large intestine. They biopsied all the way through, found them, but
He does stool on his own, but I think it's more motility.
Yeah. Like I said, I mean, everything sort of, and there's so many factors that come into play with pooping. It's hard to know. So, I mean, the absolute diagnosis of Hirschsprung's is the lack of ganglion cells. Ganglion cells, as I tell families, they're the nerve cells that make the colon work and move, or the bowel work and move. They look like little starfish if you look under the microscope, sort of, in the sense that they have the cell itself, and they have very long sort of arms that help the bowel move. So when we do the absolute diagnosis, they have to have lack of ganglion cells, and you may hear this term, they have to have normal nerve trunks. So those are the arms of the cells that come out. And so if you have a diagnosis of the lack of ganglion cells and hypertrophic nerve trunks, that's a diagnosis of Hirschsprung's disease. You can't really have no ganglion cells and good nerve trunks. That's sort of like a in-between sort of thing. All right, so contrast study, or how we know that you have Hirschsprung's, the first screening test is usually a contrast study, because that's it's a little bit invasive, but there's not tissue, there's not, putting anything or taking samples out. And so nerve cells in development, so when the baby is in mom, the nerve cells develop from mouth down to anus. And so the way that we diagnose it is the contrast study, which I'll show you some pictures. And then we look for those nerve cells at the very bottom, which is just right above. That's why when they're babies, it's easy to do. We can do it at the bedside. It's just a little sort of snip test. As they get older, it gets a little bit harder, and we have to take them to the operating room. So this is sort of the contrast study. What it entails is a little catheter going up the baby or child's bum, and we put contrast. We put a dye in there, and we take x-rays to look at it. And what we're looking for is the difference. The difference, can you see my pointer up there?
no.
Then I gotta use this one. Oh, there, it's not visible on here, right? Okay, I'm using my fingers. Okay. All right. So we're going low key. So what essentially we're looking for is, when you don't have nerve cells, the colon gets very spastic and it doesn't relax, all right? And so when that happens, the colon or the rectum becomes very narrow. So this is abnormally narrow, and then it becomes larger because the stuff upstream is trying to push through the narrow stuff. And so the test that we look for is that difference. So this should actually be bigger than the top, but it's smaller than the top, and there's numbers and ratios that we look at. But you can see it's very narrow going to something very large. So historically, they always thought this is normal, this is abnormal, and people would take out this part. This is like years and years ago, right, before this whole diagnosis. But really what the abnormal part is the skinny part, okay? So the diagnosis that we do at the bedside is, when they're a baby, is called a suction rectal biopsy. So essentially it looks like a little gun. It looks like this thing here. This goes in and snips a piece of the tissue. And then the pathologist looks at it under the microscope. And up to about 3 months of age, you can do it this way, because they'll give us the answer. They'll usually give us good tissue. Once you get older than that, we have to do a full thickness rectal biopsy, because the colon A is too thick, and B, it's hard to hold down older than a 3-month-old to be able to do this test. They're gonna squawk, and we usually can't get a good tissue sample. So they get a sedation, they go under anesthesia, and we actually take a piece of bowel under visualization to get a sample. The surgery itself probably takes about 10-15 minutes, but there's a whole thing around it, which is probably about an hour, hour and a half that things would happen. And then what we're looking for is something called ganglion cells. So this is normal. Not that you want to look at the school time, but these are normal, so the little purple cells, they're called ganglion cells, and in Hirschsprung's you can't see them at all right? And so it's very stark. And then similarly, we look at the nerve cells, and these are different tests that we look at the nerve cells itself. The other thing that we use to diagnose Hirschsprung's, and sometimes we can do it in older kids as well this way, it's not definitive, but what it gives you is an idea that something's not working, all right? So what an anal rectal manometry, the GI doctors do it, and what it's testing is how tight the anal sphincter is and how well it relaxes. And so when your rectum fills with poop, you feel it, and you're supposed to go sit on the toilet, and your anus is supposed to relax and let the poop out. The problem with Hirschsprung's disease is it doesn't relax. So when your rectum fills up, the anus doesn't respond the way it's supposed to, and it doesn't relax, and it doesn't let the poop out, okay? Even after we do a surgery for Hirschsprung's disease, this doesn't change. And that's why kids after surgery sometimes will still have problems, okay? So that if this did change, then we've damaged something there that the kids can't control. Does that make sense? So, so when we do the anal rectal manometry, which is sometimes the first screening test if it's available in your centers, because once again, it's not putting them under sedation, it's not doing an anesthetic, they just look for that relaxation. So there's 3 surgeries that we do for this. The first one's called the Swenson procedure. So essentially, we're taking everything abnormal and bringing it down to the bottom, and bringing normal down to the bottom. So when we do the surgery itself, and I'll show you some pictures, hopefully it won't gross you out, is we take these little biopsies and make sure we find bowel that shows good cells, and it comes down to the bottom. Hirschsprung's is where we go what we say full thickness. So we take everything bad out, okay? There's been variations on the surgery because people worry about damaging things. The next one is called a Suave, where they actually leave the outside of the old bowel and bring the new bowel through the middle. That can sometimes cause problems, and so most of the people in the US, at least now, tend towards doing a Swenson. There are still some people that do a Suave. And then Duhamel, it's a different surgery where they actually leave the old rectum. Because if you don't touch that old rectum, you're not going to bother anything. And so they leave the old rectum and they bring the new colon down behind. We see a lot of problems with this if that old rectum is left too much, and if the kids really sort of pocket stool and don't empty, and sometimes we have to take that thing out. I don't know if you guys know what laparoscopy is. So you know how they take out gallbladders now? So used to have to make these big sort of incisions. There's a few surgeons who, pre my time, did a surgery where we do it through the little holes. This is sort of a gross picture, but essentially we use a camera in the belly and we help move everything around, and we're able to, this is why it's called a pull through, because we pull the bowel through the bottom. What's that? It looks like a big sausage, really. So the most important thing when we do this surgery is we want to preserve continence, right? Because, great, we make them poop, but if they're pooping in their diapers and all the time, that's not what we want. And the thing that's most important for continence at the very bottom is this thing. See that little wavy line where it goes sort of from whitish to pink? That's sort of that sensation line. That's called the dentate line. So when we do our surgery, we want to make sure we preserve that, because that will help us. Sorry. That will. It's hard to see, but you see these little wavy lines? And then see where it's a little white and then it goes to pink?
It's very subtle.
It's very subtle. It's very subtle. Yeah, it's very subtle, but that's where we're trying to preserve to maintain continence even after we do the surgery. And essentially, this is sort of what we do. I know it seems very sore. They're under anesthesia, but we put these little pins in their bum and we take out the bad part, and it gets pulled through. These are little traction sutures. This is abnormal stuff coming out. And then I can show you I think I got one more. So this is very diseased, it gets very big, and then it goes to normal. So we take the disease part out, the very big part, because we know that doesn't empty well, and we go to normal. Here you can see that this is the disease part where it's really skinny, and you can see more stuff becoming more normal. Yes, ma'am.
What if there is no normal tissue?
What if there is no normal? So we don't start doing all this pull through till we know there's normal tissue. Because we don't want to take out stuff and take out stuff and take out stuff and oh no, we don't have any normal cells. So we always make sure we know where we're going before there's normal. If there is really no normal tissue throughout the colon, some of those kids actually end up with a stoma or an ostomy where you poop into a bag. Yeah. And sort of on the extreme, this is, you can see how it's abnormal, then it's big, and then it's normal. So that's what we're looking for in the operating room, but that's also what we see on the contrast study. All right, no more gross pictures. So what happens after surgery? This is sort of, you know, now we're done surgery. I always try and warn the families. Sometimes they're like, oh, we're done surgery, everything's gonna be fine. They're gonna poop normally, we're gonna be fine, nothing. But that's not always what happens. Sometimes it does happen where we don't have to do anything else. But I would say probably about 50% of the kids, even after surgery, still have some issues initially trying to learn how to poop, trying to learn how to push through, and getting that colon to do what we want it to do. Because we're sewing something to circle to a circle, sometimes these kids need dilations, meaning we have to pass a little rod down there so that the thing, where we sew things together heal well. Sometimes we have to do irrigations. Sometimes we have to do enemas. And as Katie had mentioned, some of these kids get Botox because we know that even though we did that surgery, that anus still doesn't relax normally. And the Botox actually forces relaxation. And then a lot of our kids, we monitor very closely, monthly, every other month, every 3 months, and as you're getting better, every 6 months to every year, to have a bowel movement every day. Because what we don't want is stuff to accumulate over time and cause problems in the end. So, yes. No, don't apologize.
I know that Botox doesn't last forever, right? My daughter got Botox on her legs. So when you do the Botox and you relax the rectum,
The anus. Yeah.
And they learn how to use it, you find that you don't need to do the Botox.
So it varies. There's some kids we actually have to do repeated Botox. So some kids I'll schedule every 6 months to 3 months, every 6 weeks to 3 months, because Botox lasts, depending on the kids, 6 weeks to 3 months. What we hope is that we force that relaxation and the kids learn to how to poop around that. And there's other stuff we do to be able to do that. There's some kids who we just have to do repeated Botox, and there's some kids we do once or twice, and then they're actually pretty good, and they learn how to poop and generate that pressure to poop out.
We did our Botox before surgery.
Yeah.
Ours was,
You did it
we
before.
did it at the same time as
We
the
did it.
manometry.
Yeah, we did it. No.
Yeah.
Yeah, but yes, we did
Yeah.
it before surgery.
Well,
Yeah.
they were doing the manometry.
Yeah.
He also did the Botox.
We often do that at the same time because as the kids get older, sometimes the manometry needs a little bit of calming medicine because we're putting something in the bum. And so we often will sort of at the same time, if the pressures are high, we'll simultaneously give the Botox to just help them. Yeah.
Yeah.
We tried everything with her.
Yeah.
Yes.
Yeah.
No, she's freaking out.
I mean, we'll talk about it, but doing surgery and taking out colon if it's not Hirschsprung's, it's a big step, and there's risk involved. Like if we know there's Hirschsprung's, I know there's something I'm going after. That makes sense, right? I know that there's abnormal tissue that I can take out and I can try and make things better. If there is no Hirschsprung's and the cells are all normal, once again, we don't know if they work, but to make that jump to say, okay, we're taking this colon out that otherwise looks normal under the microscope, it's a lot of discussion, right? Because we know that sometimes even though we take it out, problems can happen years down the road if we don't actually modify things that started it in the first place. And that's where some of the adjunctive care that we do helps. And so outcomes from surgery, you know, no issues at all. Some has difficulty with stooling, some stool all the time, even though everything is normal down there, and they result in diaper rash, incontinence, and problems. So what if there's no Hirschsprung's disease? We do a very similar workup to what we would do with Hirschsprung's disease. We do the contrast enzymes, we do the x-rays, and we actually do manometry and motility testing. There's a way to test the entire colon on how well it moves. That's our gastroenterologists do that, and there's probably specific places around the country that do it. They need a motility GI doctor who does that. Essentially, they put this sensing catheter all the way through the colon during a colonoscopy, and then they monitor the colon afterwards on how well it contracts, and they see all these waves, and then they give them something to eat, because when you eat, your colon's supposed to start moving to help propel the stool, and they look at those reactions, and they also give medicines and see through the catheter and see how the colon reacts. So that's some of the motility testing that our GI colleagues will do.
Any GI should be able to do that, or do I have to find a GI that does motility testing?
Yeah. There's quite a few around the country now. Most of the colorectal centers, I think, around the country actually have a GI who will do it. But there's a few good groups around the country that will do it. Yeah.
It's worth traveling for.
Oh,
We're
yeah.
not in the Boston area, we're in Connecticut.
Yeah,
so.
we'll travel to Hampton for something like that.
Yeah. I mean, the big picture for everyone in the room is you want your child to poop, regardless of how it happens. Well, sort of. Because if your child poops, they feel better, you feel better, and everyone's happier, all right? But pooping doesn't just involve, everyone thinks it's normal, right? It's like, okay, I sit on the toilet, I'm pooping, we're good, all right? But it's not the case. And it's not the case even if someone didn't have Moet-Wilson sometimes, because we deal with all that too. But there are, you know, everything has to work down below. So we talked about like the sphincter and relaxation, all this stuff. We have to have the normal cells there. We have to have the normal genetics there, because there are some genetic issues that relate, such as Moet-Wilson. We have to talk about the motility part, like things have to move. If it's really slow, you're not gonna poop. If it's really fast, you're gonna have accidents. It's like if you get severe diarrhea. I mean, some kids, regardless of anything, will have accidents. We know that nutrition and diet plays in a part, and we know that like up here makes a big difference, right? Because there's so many connections of stress, of, you know, trauma, of that just everything is interrelated. And sometimes I think we forget about this, right? Because we know that some kids, if they've had a traumatic issue with stooling, right? So, and this is where that withdrawal, you guys probably, withholding pattern, I'm sure you guys, some of you have heard about that, you know, that my child withholds, right? Why do kids withhold? No one really knows for sure, but my sense is if you talk to the families, children withhold for a few reasons. One, at some point in time they got really constipated or they had severe diarrhea. It hurts so bad to poop. And it's not that they're doing it on purpose anymore, but it's that inherent reaction, oh my God, it hurt to poop, I'm not gonna poop again. And that is like I said, it's not a behavior that they're doing on purpose, it's just something that happens because if something hurts, I'm not gonna do it again. And depending on your child, they may be more stubborn or not less stubborn about it. You know, if they had a bad experience, well, sometimes, you know, they had a bad rash for some reason. It hurts now for mom to change my diaper. I'm just not gonna poop. And that's sort of the other thing. And I'm not saying that it's like stressful, but everyone wants their kid to poop on the toilet, right? And some families, some daycare, some is like, you don't poop on the toilet, you're gonna get like reprimanded, all that sort of stuff. So we really try and sort of stand back in the sense that it's gonna happen when it happens, for one, but we wanna help you get there to where you need to be, okay? And so, at least in our center, we actually have a psychologist that works with us. We have a nutritionist that works with us. Our GI doctor is Dr. Murrah is very open to some of this, and our nurses and nurse practitioners help with this. We also have a social work involved if things need. the whole goal of bowel management is not only to poop, but also to stay clean, right? Like I said, everyone wants their kids to do this at 18 months. I'm like, that's unrealistic. Like, I have some families coming in, it's like, my kids too, they're not potty trained yet. Like, they're a boy, they're distracted, they're doing all this. It's not gonna happen. Some of this, it just happens naturally, and we have to wait for it to happen. So when we talk about bowel management, there's sort of categories that we do. There's ones that are enemas, ones that are lactose, some that we add motility agents, and then, like I said, there's all this other stuff that we actually add in to help now. Some of this stuff that like this part, I never realized was as important as a young sort of colorectal surgeon, but now I think as a group of us surgeons, we realize this is more and more important, right? This is part of it, but this also is very important. So there's 3 categories of patients that I actually take care of. Ones that truly can't hold stool, all right? And this is from congenital issues, have had surgeries, have had spinal cord issues, all that sort of stuff. And then there's kids who are on enemas to keep themselves clean, and we're trying to switch to laxatives. And then there's kids where there's nothing really that we can find, and sometimes it's the Mowat-Wilson kids, that there's nothing like that we truly can find that's a problem that we just have to deal with and treat. This is sort of what I had mentioned at the beginning. This pooping part sometimes is the worst part of taking care of your kid because it affects everything. And you can tell from parents, it's like, I keep logs, I talk to the daycare, I do this, I do that, and if they don't poop, we know it's bad, right? And so and people, I think, in the medical field realize how important it is, even though no one really wants to talk about it. But there's no real good evidence that what I do helps, but anecdotally, I think it helps.
It helps.
Is there, like, I know you're not a nutritionist, but is there like a certain diet that you feel
Yeah.
is
Yes.
route for others?
Yeah, so we have a nutritionist work with us in our center. A lot of centers have a dedicated nutritionist. I think every kid's a little bit different. I think we know that there's certain foods that cause a problem. And the foods, it's like the brat diet, like so bread, rice, everything your kid probably likes to eat, carbohydrates, bananas, all that sort of stuff can make things worse. And so we try and give you adjuncts to help, like the pea fruits is what we call them, pea fruits and vegetables, anything orange, those fruits and vegetables will help. That's why we often will use laxatives, because we know that sometimes we can't control diet, right? So we try, but if you can't, then we add in the other stuff to help. There are some kids who can get away with diet, but it also makes the families a little bit, oh my God, they had ice cream. I mean, it's okay to have ice cream, right? But some kids are very lactose sensitive in the sense that it makes them really constipated or backed up. And there's some kids, some families I know, it's not that they're lactose intolerant or gluten allergic, but we know that if we eliminate some of that stuff, the kids do better. So.
Is there like a specific type of nutritionist that we should get for this, or just
Not necessarily. You can just get sort of a general nutritionist. Like I said, some of the more centers across the country, they have all that within the center. We have it. I know there's a few probably. There used to be a nutritionist in Ohio. I don't know if they in Cincinnati. I don't know if they still do. And there's other places that might have it. But if you have a nutritionist, I mean, it was just more sort of the fibers, the constipating diet, that sort of stuff that they can talk to you about. I'll go through that. There we go. So bowel management is and is not a way to keep kids artificially clean, right? So our goal is to keep the kids empty, but to also get out of diapers. And I think that's a lot of people's goal for their kids, so it's easier for care. And what we call it is socially continent, meaning the sense that we can empty them once or twice a day, and then they can go to school, go do about their day without having to worry about it. When we talk about bowel management via enemas, it's a way to give an enema once a day, or some way to clean that kid out once a day so that they stool, or we give the laxatives to empty out once or twice a day on the toilet if possible, to have them go to school, go to about their daily life in normal underwear. And overall the goal is, of course, to keep the child clean. So why do people have accidents? One is they're truly incontinent, like that list before that I sent, or it's something what we call pseudo-incontinence. And that's usually where things are built up. So if you have like a rock in the middle of the river, the water goes around. And same thing with a poop. If there's a big poop of hard stool sitting there, then all the liquid stool just keeps leaking around. And that's often the case that we see in some of these kids, is that they're just so constipated, they either constantly smear because they can't get that rock out, or they let liquid stool come around, which can become an issue. So when we talk about being continent, you have to be able to sense it. You have to have a normal anus that's going to hold the stool in, and then you have to have what we call normal motility, and we'll go a little bit about that. And then, of course, they have to be able to figure out, how does it feel that I need to poop, that I need to get to the toilet, which sometimes can be a hard thing, right? And for some of the Mowat Wilson kids, they may just not have that ability to do that, and so then we sort of help with our adjuncts of care. So what does motility mean, right? So motility means you want to go down the river, everything's moving slowly and quick, at your own pace, and you sit and you go when you want to. You don't want to be stuck, right? You don't want to be stranded, and you don't want to be so fast, because if you're pooping 6 or 7 times a day and it's liquid stool, that kid's never going to be continent, because there's no way. You're going to be on the toilet all day long. And so what we really want to do is find that happy medium, right? So we want it not to be too fast. We don't want it to be too loose. We don't want it to be so often that it's difficult to control. And if that's the case, sometimes we have to slow things down. Not really the case with Mowat Wilson, unless there's been a resection, or there's been removal of colon, or something else is going on. Or it's too slow, and we actually have to work on that constipation. We got to get that poop to move. We either get that poop to move either with diet modifications, laxatives, or enemas. Okay? So when they're hypermodal, they're unable to hold it. They're hypomodal is it's too hard to get out and it's painful to poop. And if it's overflow, that's when it's so hard that liquid stuff comes around. Yes, ma'am?
Earlier on you talked about something that will aid motility. What is that?
There's some medications that will aid motility, and like some of the motility doctors will use it. The laxatives will actually aid motility. There's certain laxatives that will help with that. I'll go through a little bit more detail. Yeah, go ahead. Yeah, so one of the tests that we always get is, as you saw before, remember that one with Hirschsprung's where the rectum was really tiny? This is the complete opposite, right? This is now where this is all stool that's filled up and impacted in there. And you can't poop with this, right? This is the kids that constantly smudge these, like, they look like mud smears in their underwear or their diaper, or it's like cruddy stool that comes out that looks like dry grit. Or it's like liquid smudges that come out all the time. This is where we see overflow incontinence, or where we just got to get this rock out and start from square one. Okay, and so this is. What's that? Oh, of course, yeah. So, and this is actually kind of. I mean, everyone says, "Oh, my kid poops. They poop every day." But they may not be pooping enough, right? You see something in the diaper, but if they're not emptying, they're not really pooping enough. And 2 pounds seems a lot, but I don't know. Maybe it's not. Maybe not. So when we do bowel management for enemas, there's a couple of things, and I'm just going to go through what we do and sort of how we've revised it. So usually what we do is a contrast enema, because I need to see what that colon looks like. It's not a very comfortable test, I get it, and some kids can't tolerate it, and I get it, but this is something that helps us guide what we're going to do next, all right? So the contrast enema does 2 things. One, if you use what we call water-soluble contrast, the next day the kid is constantly pooping because we're doing a mini clean-out, essentially. And 2, it gives us a good idea of the size of the colon and what we need to treat. After that, it sort of determines the course of what we do. we work with you to figure out, is this kid going to tolerate enemas? Is this kid going to tolerate laxatives? Are we going to do a combination of things? Or actually do we need to clean out more before we can actually do something? And so the rest of sort of the week or the course is a combination of x-rays, reports, you guys going back and forth with the office, and then we sort of do a huddle at the end and see where we're at. Ideally, it takes a week. But realistically, this can take sometimes weeks to months for us to get the right routine. And sometimes we get the right routine, and then a month or two later something changes and we have to change the routine, and then another month or two later something else changes and we have to change the routine. That's why we have the team that works behind us, that with our nurses and nurse practitioners that you are constantly in contact with. Because we know things change, and we may be good for a little bit and then things change, and then we have to change direction. What an enema routine means is that you're giving an enema once a day to try and empty everything, and then you're clean for 24 hours. People are like, that's never going to happen. If you get the right enema, for the most part, it does happen, all right? And so that's the whole goal, is that can we get them out of diapers, can we get them out of, pull-ups or whatever, so that we empty them once a day and then we're clean. And what it does is we put a little catheter up with a combination of like fluid and stimulants to empty. They empty, and then we wait for the stool to build up for the next day, and then we empty it again in 24 hours, okay? So this is the most part where, once again, you can see this is another contrast enema, where this is huge. These are big lumps of stool that are packed up. So our goal is to empty most of this once a day. All right?
Can you do that with a kid that's on tube feedings 24/7?
Sorry, say that again?
Tube feedings?
Yeah, we can do it with tube feedings. It's a little bit harder with tube feedings, because like I said, when you stimulate the stomach, the colon starts to move.
Right.
So if you're constantly tube feeding,
Right.
it's a little bit harder, but we can get it. We can get it.
Wow.
Yeah. Might take a little bit more work. You're not the 1 week sort of course.
Right.
You're like a little bit longer. If you don't have a dilated colon, so this is a more sort of fast looking colon where you can see all these lumpy bumps, that means that colon is actively going like this and moving and trying to get things out. So those kids, we sometimes will actually put on constipating food. So this is like different. And then they have a smaller enema, and we actually add adjuncts to slow things down. So we slow things down to a point, and then we give them the enema to clean them out, and then they'll be good. Okay? What we put in the enema varies on the child. We usually use a base of just saline, which is like salt water. Then we add the adjuncts, which are helping to stimulate that colon to work. These things are just soap. They're different types of soap. Kids respond differently to the different types of soap, and that's why we usually start with glycerin, because it's a little bit, A, it's cheaper, and then B, it's not as noxious. Castile is a little bit harder, so we add that in for the kids who don't tolerate the glycerin. Sometimes it's the other way around, like kids don't tolerate glycerin, we have to switch to Castile. Phosphate is what you can get over the counter. The problem with phosphate, over years and years of use, it can actually cause the colon to be more irritated and inflamed, so we try and cut that out if we don't need it. Bisacodyl is a medicine. You can get it over the counter. Ducalax, it gets that pill form as well as enema form, and it actually draws water into the colon and makes the colon work. This is the medicine that they always test in motility testing, because they actually give it through the catheter and make sure the colon will respond. And the other thing that we sometimes will add is Go Lightly or Miralax. This is a stool softener, meaning that an enema is only going to work if the rocks can come out. If the rocks are too big and hard and they can't come out, the enema is not going to work so great. And so we add in the stool softeners if we need to sort of draw water in to make the stool more soft and have the enema more effective.
We tried Miralax with my daughter for several years, and I was wondering if you found this. When we had her on Miralax, her seizures increased. And our neurologist called up the Miralax people, and seizure medicine goes into the body through the colon. So because we were drawing in, the seizure medicine was then going out.
there's been reports that Miralax has made seizures worse in some kids, and who knows, that could be the reason. I mean, Miralax works in the colon for the most part. We hope that the seizure medications have absorbed before it hits the colon. We don't use a lot of Miralax. We only use Miralax to soften a little bit. Some families who really don't want the Miralax, we don't use it, but I've heard that said before, and whether it's like changes the electrolytes because you're drawing fluid in or unbalancing something. We've heard that.
You only use that as sort of a last resort.
We only add it in if we need to. So Miralax is a stool softener. So the problem with Miralax is it just keeps drawing water in, and it makes the kids very bloated sometimes, and it just is a constant stream of mud coming out of their butt. I know that sounds gross. But so we try and tend towards like the stimulant. So what we want to do is the colon to contract more, and that's where I'll talk a little bit about the laxatives. We use Senna, we use bisacodyl, we use some of the other adjuncts because that actually makes the colon contract as opposed to just making the stool soft. I don't care.
I just had a question, can I add consent? So we tried all,
Yeah,
all the
yeah.
irritants, everything like
Yeah.
that, and had issues with all of them. Miralax, we were in the bloodstream.
Yeah.
Never again, we went there.
Yeah.
So we went to the Parastine.
Yeah.
And we've had a lot of success
Yeah.
with that for quite a few years.
Yeah.
What's your opinion on Parastine, how that works as an agent?
Yeah.
I
I think Parastine's great. So Parastine is just another way to give the enema. So because we teach families how to do balloon enemas. It's like this makeshift catheter that has a balloon on the end, and you sort of put things through. Parastine is a self-enclosed system. I actually have a picture of it further along. It is rectal therapy, meaning that the child has to be able to tolerate something up the bum. Parastine, often you can get away with just tap water or saline and not necessarily irrigation because it's a pump system. It's a pump irrigation system. But the same thing with Parastine. If the stool is too hard, it doesn't work very well. And so that's where sometimes the stool softeners come in.
We just do that daily.
Yep. Yeah. Yeah.
And we've been doing it for years, and
Yeah.
so far it seems.
Yeah. No, I think it's great because it's the same that we do with like an enema program.
Not putting those chemical agents in the
Yeah.
body.
Yeah. Yeah.
Okay, I have a word written down and I don't speak doctor. Will you tell me if this is that medication?
Is that the one that you were just talking about?
Pyristigmine?
Yep.
Which medication? It's a motility drug.
Motility?
Yeah. Yeah.
That's not what she was just talking about?
No.
Okay.
Yeah.
Yeah, well, my son is on lactose. Is
Yeah.
that something, I don't really know.
So lactulose, yeah. So lactulose, magnesia. Oh well, magnesia is a little bit different. Lactulose and Miralax are probably mostly stool softeners. So lactulose is like sugar.
It's definitely stool softener.
Yeah, it just draws water in, so
Is
it's
that
like.
something that like if he's on it for a long period of time, it's going to?
Probably not. I mean, you can titrate lactulose, but the same thing with lactulose as is with Miralax. The more you use, the more it just makes you sort of bloated and gassy, and just has liquid stool coming out.
Okay, and now this drug,
Mm-hmm.
what do you know about that?
So that works on the sodium channel receptors in the colon, and it's supposed to draw water in through sodium channels as opposed to something local. So Miralax and lactulose hit the colon, and what it is it draws water into the colon because of its components, which makes the stool loose. The pyristigmine it works on the sodium channel receptors in the colon to put more water into the stool. If that makes sense.
It sort of makes sense.
Yeah, yeah.
There's
It's all.
a kid who is getting his like full workup. Omar, Linda's kid. Anybody who read that whole thing? She's been like in and out of doctors for a while. They use this. It's completely emptied him out, and
Yeah.
he's like become totally great.
Yeah, yeah. It's a pretty decent motility drug if it works. Not everybody responds to it. Yeah. That's the problem. Like every kid's a little bit different, so you have to sort of. It's a little bit trial and error, right? You try something and this is sometimes why it takes so long to get clean. Like I know enemas are going to get you clean right away. If we're starting medications, it's sort of a trial and error. How much dose? How much do we need of this? How much do we need to get the child to empty and stool? So it becomes a little bit more time intensive for you guys because you're trying everything. You can't just try it for one day, right? You have to try it for a little bit to see the results and see what happens.
So, she just has a 1-year-old, and he will seem constipated occasionally. And you know those Wendy things?
Yeah.
Well, we use that with Vaseline, and that seems to work well. But is that completely emptying his colon?
I mean, it could. Like sometimes it just pockets down at the bottom, and sometimes it's truly the tone down there, right? So they just can't relax to poop. They may not have Hirschsprung's disease, but it's just that anal stimulation that lets them relax, and everything comes out. And Wendy's, we use like the glycerin Pedialyte suppositories a lot. It's like a liquid suppository, which is like, it looks like an orange bubble with a stick on it. I think those are great. I use them on the babies all the time because it sort of gives them enough stimulation that everything relaxes and things come out.
And like doing it every day, sometimes the Wendy's, sometimes you have to do it multiple times a day.
Yeah.
That's not gonna like.
No, that's okay.
I always feel like it's so.
No,
bad.
no, it's okay.
When I was doing those, and like not the Wendy's, but the bulbs,
Yeah.
the little
Yeah,
pediatric
yeah.
ones, and getting stool every day, we thought we were doing great until we got the contrast
Yeah.
study, and
Yeah.
then we were like, oh shit, literally, because there was like
Yeah.
a
Right.
lot of it. And once he had that contrast dye in there, it was 12 hours of nothing but coming
Yeah,
out.
yeah,
Because it
yeah.
would get all up.
We
Yeah.
did a Hirschsprung's contrast thing, and he was just pooped during it. And we were like, okay, well it's working. Like,
And it might be it's different
it
once
does
he eats
have
solid
Hirschsprung's
foods though.
eventually.
So that might be a change going from one.
Right,
Now that
maybe
he's
getting
gonna start
more
eating solids, you might have you're gonna have to navigate those changes.
Yeah.
I mean, there's time points for us that we follow kids a lot more closely, right? So we follow them initially, we get them on a good routine. When they start solids, we sort of follow a little bit more closely. When you're 1 and you switch to like milk and off formula and off breast milk, we follow a little bit closely because everything sort of goes in for a whirlwind. Milk, like cow's milk, often will make kids really constipated. And once they switch, they are so constipated. And so,
Choose something that's not cow's milk. 'Cause
yes.
My mind is not.
Yeah, I mean, there's people who use soy, there's people who use goat's milk, some people stay on some type of sort of pediatric formula, not a baby formula anymore, and that's totally fine. Yeah.
My daughter's
Yeah, I mean,
My daughter happens to be allergic to like everything.
yeah.
So we found Ripple is made
Yeah.
from peas, and she can tolerate Ripple.
Yeah, yeah. Ripple.
At Target, which is such a blessing.
Is it at Target now? Because people
It's a
used to
big
have to
box.
order it. Actually, I think it was
Yeah.
is made in Europe, and people used to
Yeah.
order it in bulk from Europe.
Yeah, it's Canada. They make it in Canada.
Well, there you go.
It's coming down.
That's Canadians.
Yeah.
Unless you're allergic to peas.
Yeah.
My daughter's 29. She's very small in it, but we've used Miralax every day for years and years and years and years and years. Because if we don't use some every day, then she doesn't go.
Yeah.
And sometimes she goes, she really goes. If she doesn't go for a few days, then we do the Senna and that, but I'm just wondering, is it okay to do Miralax every day?
Yeah, it is.
Or should I do, because she is incontinent, she does wear diapers, but you can put her on the toilet.
Yeah.
Toilet.
So what you want is what's best for you guys. I mean, this is how I always frame it to the family. If the Miralax works and you're not on a ton of Miralax and she's not constantly stooling every day, because there are some people who are like on a little bit of Miralax and are totally fine, right? Our preference is to help empty better is to put them on a stimulant. It doesn't mean you have to come off the Miralax completely. Sometimes it actually just reduces the amount of Miralax you give. But the story you tell about Miralax is very common, is where they don't poop, I'm giving it, and all of a sudden the floodgates open and things whoosh out, right? And so to keep it more consistent, sometimes the stimulant laxatives will help to keep you going a good amount every day.
So what Because
Let's
our
just go
doctors-
there. How about that?
We don't have any doctors that know anything about MWS, and they really don't know how to handle her.
This is what Paristine is. Yeah, so this is what Paristine looks like. This is sort of a self-contained system. Unfortunately, not every insurance company covers it. So that's the biggest thing about Paristine. You know, from our perspective, there's some insurances that cover it and we have no problems, but there's some insurances that don't cover it and we have to fight for you guys, and sometimes it still won't get covered. This is the other option of giving, I don't know if you guys heard of appendicostomies. So it's a way to do an antegrade flush in the sense that essentially we take the appendix and we tack it to the belly button, because a lot of kids don't like stuff down here. If they can see things happening, they're a little bit more comfortable, and you just pass and do the enema from above. Essentially, you're washing everything out from above.
It would take 4 of us to hold her down
To do this?
to do anything
Yeah,
like that.
yeah, yeah,
If you get a routine though,
yeah.
and they get used to it, it's not, I mean, they can adjust to it.
And it's crazy because what you're saying is what I hear a lot, and then we do this and the family's like, oh my God, she can see it, she lets us do it, there's no problems, and they get used to it. And this, you'll be amazing to see the difference when somebody's trying to go up your bum versus doing something from above, because they feel like they can see, they can control it a little bit. But the other option, if you can't pass a catheter every day, we actually leave something that looks like a little feeding tube in there, so, and you just connect it up. And so sometimes that helps with the kids. So.
Can I say anything about it? Can I say something? So, when I used to try and give my daughter suppositories, or we use the Fleet liquid glycerin enemas now, when I used to try and put them in when she was not on the toilet, it was the biggest fight, right?
Yeah.
She's pretty strong.
Yeah.
But I learned that if I put her on the toilet, and then I went from behind and I gave her the liquid glycerin suppository where she's already relaxed, she's already thinking that stuff's coming out, it's like not a fight at all.
Yeah.
So she does kind of the correlated,
Yeah.
you can do that.
Do it on the toilet.
My son
Yeah.
takes me into the bathroom now at 7:30 at night to do it. He wants to go. He's like, come on, let's do this. I want to get this going. Yeah, he's
Well, I
excited.
mean, part of it is they feel better, right?
Yeah, they feel better.
When they're empty, they feel better, and if they don't, get that empty feeling, they don't feel good.
After Eli goes to Liberty class now. He's like,
Yeah.
okay, right, buddy.
Yeah.
We're on the same page.
Yeah. So, I mean, it's the same thing as your daughter's 29.
Mm-hmm.
At some point in time, it's going to be harder and harder for you to help her, right? So I get a lot of older patients come in. I'm like, and the families are, we need to do something to help her, potentially in the future, right? If you're, need someone else to help her. And so that's a good way. Paristine can be a way that other people can help her with. And I don't like to offer it, but some kids actually do better with a stoma, right? With an ostomy, where they poop into the bag, where there's nothing down there, there's nothing up here, and you just, whoever the caretaker becomes in the end, it's a lot easier on them because they can just change things. Yeah.
You said you don't offer that. Like,
It's because it's a big quality of life lifestyle change for families. If families come to me asking for it, no problem. I always give it as an option, but from my experience, it's all the way down here the line for most families, right? There's some families I will say that, okay, this colon is not going to work for some reason or another, that we should just do a stoma. And when we do that for those families, sometimes they're the happiest people around because they don't have to worry about dirty diapers. They don't have to worry about all the medicines that we have to give. They don't have to worry about, and the child feels better. So, just my experience, most families don't want it.
yeah, I don't want it.
Yeah.
But it becomes a problem of irrigating, like we irrigate him
Yeah.
twice a day.
Yeah.
He's getting longer and taller.
Yeah,
And so
yeah.
at some point, I'm an ostomy nurse. So
Yeah.
at some point, I think that it might be more difficult to
Yeah.
irrigate
Yeah.
him.
Yeah.
So is that the only other option?
An ostomy?
Yeah.
Not, well, that's where we can do things from above, like the appendicostomy, the cecostomy, all that sort of stuff. Sometimes will help. So. But there are some families who decide early on that I want an ostomy. That's
easy to manage.
It's easy. It's easy enough for me to say that, but it's hard for the families to accept it. Let's put it that way. The ones that we do end up doing it for, the families are happy in the end. So, yes, sir.
My daughter is 24, and she's very much like you were saying, man. She's been on Miralax for years. We give her magnesium citrate.
Yep.
Being that a buffalo, but it doesn't seem to make a difference. She is very irregular. She pretty much goes every day, but the Miralax helps keep it softer, and she does fight having bowel movements.
Yeah.
She wasn't diagnosed with Miralax until she was 15, so by that time, we can give lactulose, Miralax, all these different things.
Yeah.
But do you know if we can over live that we could go? She has her own. She has to go every day. Just give her enough Miralax, she goes every day, and it's a mess. It's just constant.
There's Dr. Callisto, and I think he's in Tampa. I don't know or exactly where he is, but there is a colorectal center down in Florida. Yeah, there is a colorectal center in Florida.
Okay, we need to go to somebody that does just give them Miralax.
Yeah, I can't remember if he's in Tampa or Miami, but they're in the Florida area. Yeah.
Can I ask you, just because I have this issue, I have this problem with my son, but I know a lot of us have older kids too. So I found that my son eats excessive amounts of food. And I wonder, since he didn't have a pull-through or any segment removed, and I've read somewhere that there is some correlation with malabsorption issues possible when you don't have a pull-through versus when you do. What's your opinion on that?
Your child doesn't have Hirschsprung's though.
Functional Hirschsprung. He doesn't
Right.
have diagnosed Hirschsprung, he is functional.
Right, meaning that he's on some sort of spectrum. He doesn't poop every day.
He's never pooped on his own.
Yeah. I mean, when we talk about malabsorption, it's like absorption of nutrients, right? Most of your nutrients are actually absorbed above the colon. And so if there's a lot of the malabsorption, kids actually poop a lot. That doesn't necessarily mean that's your child. But for the most part, there's ways you can test the stool if they're like dumping certain things. And the GI doctor can sort of help you with that. Yeah.
He eats like 5,000 calories a day. He's literally around.
Yeah.
Like he's
Yeah.
so scrawny.
That and how much calories does he actually burn a day? We never, I mean.
It just seems like
Yeah.
the ratio is,
Yeah.
I don't know.
Yeah. But I mean.
Watching Billy put the dinner down last night. I was like, man, that girl's too. They're
She's
small.
tiny. But I think they probably burn more calories than we think.
Yeah.
I mean, they're constantly moving, right? And so that's burning of calories. And so if they need that much calories to grow, I mean, what you want is your child to be in a good sort of BMI, growth, height sort of thing. And if he's fine.
Made it on the growth chart.
Yeah, and unfortunately, he may still be doing catch-up, right? So some kids are really small, and then we know that they actually need more calories as they're growing because they're burning more and need to catch up. So. How much time do we have? We're almost done. Here, let me go.
I mean, there's a coffee break, so it depends on if these guys want to hear you.
So these are the laxatives that we usually use. We use senna-based laxatives because it's cheap. I mean, and so we use senna, which you can get in liquid pill, and X-Lax is actually senna. The other one that we use is bisacodyl. These are sort of the common drugs that we use. Bisacodyl is over-the-counter prescription drug. It works a little bit differently. It's a little stronger. The other medicines, and every kid's different, and that's why we sort of try different things. The other ones that we use are Linzess, Amitiza, and Motegrity. So these are sort of more motility type drugs. Linzess and Amitiza are like a lot of the families who have sort of, I don't want to say it's irritable bowel, but some kids who have a lot of pain, who have a lot of inconsistency with stooling, Linzess and Amitiza are great. Motegrity is truly a motility drug in the sense that it makes everything move a little bit easier. And Motegrity is a little bit newer on the market. We use it with a lot of our motility kids, our dysfunctional sort of kids. And this one, I think Motegrity works really well in kids with like what you may be describing as your son, who's sort of Hirschsprung's but not Hirschsprung's, because it just helps everything keep moving. The problem with Motegrity is if you're not 18, getting insurance to pay for that is awful. Why? Because it's insurance. Because it was created in adults, right? So all these drugs were tested in adults, and if it's not proven in kids, it's really, the insurance companies have this. I grew up in Canada, and I never had to deal with insurance until I hit the States, and I'm like, this is like wild. I mean, but even it's getting worse, and I'll be frankly honest, like some families can't get their enema supplies covered now because the supplies we're using aren't created for bowel management. They're created for urine, they're created for feeding, so it's not an indication, and they'll deny coverage. Some of the medications we want to try and use, they don't cover, partly because it's not proven in kids. And over the last, I want to say 5 years, it's gotten a lot worse. I mean, we try and help you as much as we can in the sense that we have a social worker who works with us, we write letters, we have our GI motility experts weigh in, so there's multiple letters that go out to try and get things covered.
Does that work?
Sometimes. And then sometimes we have to put you on a study drug. Dr. Nurko, who's one of the GI doctors who works with me, has a study on some of these medications for dysmotility, and he'll put you on the study drug, which then, of course, it's covered. So these are all sort of different ways we try and get around things. I think we're out of time, right?
Almost, yeah. 3
Um,
minutes. 3 minutes, technically.
So this is like extreme case, and sometimes we have to take things out, right? So this is the size of a normal pen, and this is huge, right? And so when we see things like this, sometimes they need surgery. All right?
They need a what?
Surgery. So this is sort of like what we have in our Center for Adjunctive Care. These are some of the foods that we say are good and bad.
Hold on to that for a second.
So those are bad, these are good.
Yeah.
All the things that you're like.
These are constipated sometimes.
Oh, those are constant.
Yes.
Yeah.
Wait, sorry. These are
Yeah.
constipated, the app.
It's a little bit mixed up.
It is a little bit.
It's a little bit mixed up. Let's redo that one. We'll go back to that. This is how we do Botox, and what it does is actually relax the sphincter in the pelvic floor. And then we actually have.
Sorry, is that something that everybody in your field is like
Botox?
doing? Yeah.
A lot of us do it.
I have to like fight my doctor for.
You shouldn't have to fight. A lot of us do it.
Ours recommended it to us.
Okay.
A lot of us do it. And I'm just going to put it out there. There is insurance companies that will also deny Botox, and so we have to work around and say, sort of fudge the diagnosis and everything to get it covered. Because I've had families sort of get stuck with the bill for Botox, which we don't want. We're using a lot more pelvic floor therapy now, so relaxation to techniques, how to relax the pelvic floor, how to teach the kids to actually generate enough abdominal pressure to help poop. We find that when we've added pelvic floor, we're having a lot more success in our kids. There is, like, you have to be able to coordinate, and they have to sort of be able to feel it and do what we want them to do. So there is a developmental component to it, but there's specific pediatric pelvic floor therapists who are great and able to do that.
Well, if the kid is, getting around, he's feeling it, right?
He's feeling it, but he may not be relaxing till it'll come out. So when the kids are red-faced and pushing and pushing and pushing and the poop's not coming out, they're probably tightening everything there. And so as much as they poop, they may not be able to get it out because you think they're pushing, they think they're feeling it, but they have to be able to relax to get the stuff out. And that's where the Botox comes in, right? It just forces them so they can't make it tighter.
Is there any issues with, like, if there's normal pooping, but they have that relaxation problem and you do that, then...
Are incontinent?
Yeah.
There's sometimes temporarily you could be incontinent for a little bit, and then it sort of comes back. Yeah, because the Botox is temporary, and you know, kids who are continent are stooling on the toilet, we may give a little bit less Botox so that we know that they can actually not completely have complete relaxation of it. So, just what we do in our center, we actually offer bowel management virtually. We have to see you once again, for insurance's sake, but we do a lot via phone and email. And then I'm gonna just... This is sort of a list of centers. It's probably not comprehensive, but it's what, if you go on the pull-through network site as well, a lot of the sites are listed there. But that, I don't know where Nicholas Children's is. Is that in Tampa? It's in Florida. That's where Dr. Callisto is.
Okay.
So.
Orlando Health.
Yeah. Yeah, so there's a, yeah.
So I live in Chihuahua land, and Lurie's is by me, but my daughter's 29.
So you get kicked out.
Yes.
So, like in your center, do you see?
We will initially see. Eventually, we can't do surgery on them. After, I think it's 30, it's a hard stop, and we have to get permission. Over 35 is like an absolute no. We know that some of these kids are still within sort of a pediatric care model, and so we try and help if we can, but once again, it's getting harder and harder to help with the adults. There are a couple places in the country who have adult colorectal surgeons who are within the pediatric centers. Like Nationwide actually has an adult colorectal center, a surgeon who works with them. I think now Children's National in DC. What's that?
Nationwide in Ohio.
Yeah, Nationwide in Columbus, Ohio. We have motility experts on the adult side, but adult care, as you can imagine, is very different than pediatric care, and some families go there once, and I'm like, can't do it. So, I mean, I do see some adults. We try and help and try and navigate for you as best as possible and try and find providers that will work for you. It's a big issue, right? I mean, the transition care piece for the older young adolescents to older adolescents to adults is we're feeling the crux now, and so we're trying to engage our adult colorectal surgeons. The problem with adult colorectal, they deal with cancer. You know, they deal with like adult problems. They don't deal with adult children. I'm saying it as adult children. But.
So motility centers are only for peds?
No, there's adult motility centers.
Okay.
Yeah.
So, I mean, my daughter had the test for her sprung.
Yeah. Yeah.
And what the gastroenterologist said was that she has reduced ganglia cells.
Yeah.
But she doesn't qualify for that Hirschsprung's
Yeah.
diagnosis.
Yeah.
But pretty much in her whole life, she's only had a BM on her own maybe 10 times.
Yeah.
So we have, like, we use the Senna with stool softener, we use magnesium, and then we do the liquid glycerin suppositories every other day.
Yeah.
But I think listening to this, we need to have more checked out. So.
Where can you go?
Right.
My guess is if you're in Chicago, the people in Nationwide might be able to see you because Dr. Gazer there is an adult colorectal surgeon who works within the pediatric world as well, so she may be able to help you. We will see adult patients sort of as an initial consult and help you, but long-term wise it gets very hard for us. We're far from you too. And then you can try an adult colorectal GI person, but my guess is they're going to tell your daughter to get a stoma because that's usually what they've suggested when we send people over.
You know, it's funny, like we transitioned our daughter because Northwestern opened a hospital right down the street from our house. So I started transitioning our doctors to Northwestern. And we've seen the gastroenterologist once. And I came because I really didn't understand like all of these issues to ask her questions.
Yeah. Yeah.
So I think that I'm going to talk to her. Is your presentation going to be available?
Yes, they're recording.
Right.
All the
Well, when
presentations.
will it be available?
I don't know exactly, but I can.
Okay. Just because I want to talk to her about all of this, and if I don't get any positive results, then I can go.
Is she still at Lurie Children's then? They're still taking care of her?
No.
Oh. Oh, Northwestern Adult Northwestern. Yeah.
Yes. But you know what? Lurie's and Northwestern are attached.
Yeah.
So I wonder.
They do have a colorectal center there
Yeah.
for children. I don't know if they'll see her, but every hospital is a little bit different on age limits. Like most hospitals, peds hospitals say 18, maybe 21. Our hospital says as long as you're under parents' insurance, we can still see you as an adult. If you're an established patient at our hospital, we can probably still see you without too many questions. If you're a brand new patient, it makes it a little bit more difficult and it's provider dependent, but you know, I see some for initial consultation and just say this is what we should do, and we do the workup and everything, and then at some point in time I do have to figure out how to find you an adult provider.
So we could possibly see you
Yeah.
get the initial workup.
Yeah. Yeah.
And then we could transition to here to Northwestern.
Yeah.
And I think the doctor that we're seeing, Dr. Lou, I think she did work with pediatrics, or she does work with pediatrics.
Yeah. Yeah.
So, okay.
Yeah. I mean, across the board for pediatric care, transition is the hardest part right now.
Right, and that's kind of